Welcome. My name is Marco Grossi, student physical therapist with the University of St. Augustine. I will be giving this case presentation today on my patient who is a veteran of the United States Marine Corps and I feel serves as a representative of all the armed forces. Grosso et al. Wrote in a 2017 study in the American Journal of Preventive Medicine that chronic low back pain is one of the most common impairments afflicting the veteran community. With opioid use soaring amongst the same population, it is imperative that we are able to diagnose and treat these patients through non-pharmaceutical therapeutic modalities. Through this case, I will discuss common patterns of presentation of back pain as well as evidence-based interventions in which to treat them. My patient is a 31-year-old endomorphic female who reports of pain in the left cervical and left lumbosacral regions. She currently works as a property manager and essentially spends her whole day working at a desk. Prior to this, she had a 5-year history in the United States Marines where she first reported suffering from low back pain. Utilizing the numeric pain rating scale, NPRS, which rates pain from 0 to 10, 0 being pain, no pain at all, which Abbott and Schmidt describe as having excellent reliability and validity in their 2014 article in the Journal of Orthopedic Sports Physical Therapy. She describes both sources of pain as being constant dull aches, which rate at a 5 out of 10 for the lumbosacral area and a 3 out of 10 in the cervical region. She reports the pain is at its worst when she is sitting at her desk, which prevents her from sitting for extended periods of time, and is mediated by laying down flat on her back. Furthermore, the patient complains of stiffness in the neck when she wakes up in the morning, which seems to loosen up throughout the course of the day. Patient denies any numbness or tingling and has never seen a physician for these symptoms. Patient is a 15-year smoker and occasionally drinks alcohol. Additionally, the patient used to be an avid jogger but has been forced to cut back significantly because of the pain in the low back region. Patient would like to get to the point where she can sit comfortably at work and not experience pain and hopefully return to jogging. The Oswestry Disability Index, also known as the ODI, is a patient-reported questionnaire which rates various actions based on their difficulty due to a person's disability. According to Copay and Share in their 2016 article in the Quality of Life Research Journal, clinicians may rely on the ODI to measure disability caused by sacroiliac pain with strong validity. Upon our evaluation, this patient of mine scored a 22%, which according to the ODI is classified as a moderate disability. Upon structural examination, the patient presented with slight forward head posture, rounded shoulders, and with the left anterior superior iliac spine superior to the left posterior superior iliac spine, which equates to a lowered iliac crest in standing. During the range of motion assessments on the patient, I found them to be limited in cervical side bending. However, when the arms were supported to put the trapezius muscles on slack, there was a marked improvement in side bending. This led me to suspect a myofascial restriction pattern. Upon goniometric measurement, the patient measured 30 and 35 degrees for left and right side bending, respectively, and 55 and 75 degrees for left and right rotation, respectively. The patient also reported tenderness upon palpation of the upper trapezius and suboccipital musculature. During a deep neck flexor endurance test, where the patient is instructed to tuck in their chin and flex their head forward in a supine position, the patient could only hold the position for 15 seconds before fatiguing, indicating a lack of endurance from the deep neck flexor muscles. Upon examination of the lumbosacral area, the patient presented with a positive sacral spring test, which is a quickly applied anterior force applied through the sacrum on a prone patient. Additionally, the patient presented with a positive lag test in which they are asked to bend forward from a standing position, and the left posterior superior iliac spine lagged behind and rotated only after the right PSIS began to move. When the patient was evaluated in the supine sit test, where leg length is compared bilaterally in supine then sitting positions, their left leg appeared shorter in supine and then longer in sitting. In combination, the previous 3 tests seem indicative of either a hypermobility or the left sacroiliac joint being stuck in posterior displacement. I proceeded to follow up this evaluation with the March test, which includes palpation of the sacrum and ilium during standing while the patient actively raises each thigh. This test was found to be negative, showing dissociative motion between the sacrum and ilium. It is also important to note that during palpation, there was hypertonicity noticed in the left lumbar erector spinae musculature, as well as tenderness over the posterior sacroiliac ligaments. Based on the above findings, I have diagnosed this patient with neck pain with mobility deficits and lower back pain with sacroiliac joint hypermobility. The cervical diagnosis is based on the patient's location and description of pain, along with the limited range of motion in side bending and forward head posture. The lower back pain diagnosis is based on the patient's description of a dull, constant pain coupled with the positive lag test, the positive supine to sit test, and the positive sacral spring test, as well as presenting with a lowered left iliac crest during structural inspection. These tests could have been indicative of a posterior displacement of the sacroiliac joint, but was ruled out because of the dissociative motion that was felt during the March test. My prognosis of the patient is good, based on her relatively young age and motivation to perform the necessary interventions to rid her of her pain. Patient has a dedicated attitude and shows a high potential for compliance. Patient is expected to significantly reduce pain and increase activity levels in 4 to 6 weeks. The patient's long-term goal is to, within 4 weeks, be able to run 1 mile on a level treadmill in under 9 minutes with an NPRS of 1 out of 10 or less. The primary impairment for this patient is the hypermobility of the left sacroiliac joint. According to Yu in his 2015 article in the Journal of Physical Therapy Science, an effective intervention is stabilization exercises to improve sacral nutation torque. The 3 exercises he recommends are firstly, focusing on the erector spinae, which to perform would include a straight leg deadlift with 5 kilogram weights in each arm. During this movement, there will be emphasis placed on maintaining a natural arch of the back and maintaining retracted shoulder blades and performing the entire movement over 10 seconds. That would be 5 seconds down, a pause, and 5 seconds back up. The second exercise would be an abdominal crunch to strengthen the rectus abdominis. And lastly, there would be a hamstring curl with a resistance band in a prone position to strengthen the biceps femoris. All of these exercises are to be performed in 3 sets for 30 repetitions each. The second impairment for this patient is hypertonicity of the left lumbar erector spinae muscles. According to Churkin et al. In his 2011 article in the Annals of Internal Medicine, soft tissue massage therapy is an effective intervention in reducing hypertonicity and balancing agonist and antagonist muscles. The third impairment for this patient is limited cervical side bending. According to Park et al. In the 2013 article in the Journal of Korean Physical Therapy, stretching of the trapezius muscle, specifically in a more tense position, is an effective treatment for increasing the reduced cervical side bending in patients with unilateral neck pain. The fourth impairment for this patient is weakness of the deep cervical flexor muscles. According to Kim and Kwok in their 2016 article in the Journal of Physical Therapy Science, an effective intervention is known as deep cervical flexor activation exercise, in which the patient is in a supine position and maintains a flattened cervical lordosis while keeping the sternocleidomastoid mastoid and anterior scalenes relaxed and maintains 30 millimeters of mercury pressure on an airbag that is placed under the neck for a period of 10 to 15 seconds and repeated 10 times with 3-second rest periods. It should be noted that I would also recommend the transverse abdominis draw-in method with this patient, as Park and Yu noted in their 2013 study in the Journal of Exercise Rehabilitation that the use of this intervention for chronic low back pain shows a significant effect on the decrease of ODI. These interventions would also be followed up with significant patient education on maintaining neutral sitting posture and possible ergonomic mediation in conjunction with the daily home exercise program. In summary, my patient presented with chronic low back pain and neck pain of a constant and dull nature. She was found to have hypermobility present in the sacroiliac joint with hypertonic lumbar musculature and limited cervical side bending, coupled with weakness of the deep cervical flexors. She was recommended to be treated using multiple modalities consisting of therapeutic exercise, soft tissue massage, stretching, and patient education. It is crucial to note that this treatment plan is completely non-pharmaceutical and hopefully establishes a guideline for management of back pain without medication. Thank you.